It is my pleasure to welcome you to today's online journal club. It is our pleasure to have Professor Kluin-Nelemans from the Netherlands with us. She is professor at the Department of Hematology, University Medical Center in Groningen, Netherlands. She is member of the European Mantle-Cell Lymphoma Consortium, and she is principal investigator and first author on a very important study on the treatment of Mantle-Cell Lymphoma in the elderly. That study was published last year in August in the New England Journal of Medicine, and I think it has a significant impact on our daily practice. Beside me, on the right-hand side for me, is Dr. Stenner from the University Hospital in Basel, and myself, I'm Christoph Renner from the Onco Center in Zurich. So, Professor Kluin-Nelemans, can you briefly tell us about the concept of your study you performed and about the data?
Okay. The study was designed in the early of the beginning of this century. And well, in those years, the outcome of elderly patients with Mantle-Cell Lymphoma was very poor. And R-CHOP was considered then the kind of standard. And fludarabine was coming up. And we wondered whether a combination of fludarabine would have a better outcome for induction, more complete remissions compared to R-CHOP. So that was the first part of the study, a first randomization, R-CHOP versus RFC. And then, because we know Mantle-Cell Lymphoma patients all relapse after induction, we in addition had a second randomization to focus on improvement of maintenance. So we wondered whether the addition of rituximab for maintenance could be better than what was considered a kind of standard low-dose interferon alpha. So we designed a study with 2 randomizations for elderly patients. That was a bit risk, of course, but we succeeded, and 8 countries participated, and we succeeded in entering 560 patients between 2004 and 2010. And well, the first part, the question whether RFC was better than R-CHOP was rather disappointing, because that was not the case. RFC did not succeed in more responses. Even worse, there were more patients who had early progression, and many of them rapidly died afterwards. So there was no salvage regimen then feasible for them. And moreover, it appeared that RFC induced a lot of toxicity, many infections. So if we looked at the survival curves, RFC versus R-CHOP, RFC showed us a rapid downhill of the curve because of, on the one hand, more progressive disease, and on the other hand, more early deaths due to infections. So that was the disappointing part of the study. R-CHOP appeared still better than RFC. But then the second part, the maintenance, we had rituximab versus interferon alpha, and then it appeared that rituximab improved a lot. There was a very significant difference in favor of rituximab maintenance. And if we split it up and looked at the patients who had been pre-treated by R-CHOP, then it appeared that those patients who had a response upon R-CHOP, that was about 80%, and could go on with rituximab, that they had at 4 years still a survival of 87%, which was unbelievable well for such a disease, Mantle-Cell Lymphoma in the elderly. So we feel that with those data, R-CHOP followed by rituximab until progression should be the standard. Okay. Still, there is a lot to improve further, but that's for the next study. Probably you will ask questions on that.
Yeah, thank you very much.
Yeah.
Fine.
Yeah, what you just said was that there was a long phase of non-progression in patients who had rituximab maintenance, and when you look at the 2 arms, it was even more astonishing. In the R-CHOP arm, the patients had an even greater benefit, and they haven't reached the median for overall survival. Do you think there is a hint of cure for some of these elderly patients within this, or do we have to be cautious when we use this?
Yeah, I think we have to be cautious because the curves go down still. And probably with minimal residual disease measurements, we could select for a small group who will show a kind of plateau, but that's far too early. I feel that it still goes down, and that even rituximab, although it is wonderful, still needs a further improvement to see whether we can indeed at the end cure some patients.
Okay, a bit provocative question. Interferon and fludarabine are completely dead in mantle cell lymphoma?
Interferon probably is. There was a lot of reluctance before starting already because it causes a lot of toxicity. In elderly patients, there were many dropouts, only not because of progression, but because of toxicity. And I still think that RFC, if you are carefully dosing it and if you are aware of the toxicity, is very effective. But R-CHOP was better, let's say, in such a big study. But if you ask for, let's say, a salvage regimen for those patients who relapse upon R-CHOP, I think RFC could be a second salvage regimen.
This study was, so to say, completely cytarabine free. And we know from the younger patients that this drug may have an important role in the treatment of mantle cell lymphoma. Do you think there's room for improvement, and are there newer studies incorporating this agent for elderly patients as well?
That's a very important question. For a long time we considered RFC too toxic for elderly patients, but then there has been a salvage regimen which was kind like RT-HAP, but then without the cisplatin, and an adapted dose of the RFC, and that seems feasible in elderly patients who relapsed. So we went on, and we will start a new large phase 3 study where we will incorporate the kind of RT-HAP scheme, but then without platinum. We call it R-HAD, and that contains rituximab, high dose RFC, but then 1 gram per square meter, just on one day, two doses. And then the dexamethasone of the scheme will be 20 milligrams instead of the 40 for 4 days. So it is very much adapted. And we will give this alternating with R-CHOP. So R-CHOP, R-HAD, R-CHOP, R-HAD 6 times. And that's a little bit similar to the study we did in the younger patients. So it is kind of going on the design of the younger patients. And we are very hopeful that will be a better induction regimen than R-CHOP. Okay. And that the toxicity will be acceptable.
Maybe final question from my side. Not all patients qualified for maintenance. Actually, in your study, you had the hurdle that the patients shouldn't be progressive. Actually, they had to be in a kind of remission, and they must have had good hematological values. Yeah. And this is 45% of patients dropped out at this point, as far as I remember. So, in daily practice, a lot of patients will not qualify regarding to these standards. How shall we treat them? Shall we say, in an analogy, we'll treat them as if they had qualified within the study, or what would be your daily practice in this regard?
I think that the reason that, let's say, the patients who dropped out for maintenance because they were non-responsive, that will be the same problem in the future. But for the original study, we required good hematological response for the interferon arm. Mm-hmm. And for rituximab, that's not a major problem. So even if patients are thrombocytopenic, then there is no contraindication to start with rituximab. So I guess then that the number of patients eligible for rituximab will be much higher.
Okay. Mm-hmm.
And the rituximab maintenance, you said until progression. And the median duration was 25 months during that study, if I recall that correctly. So it's close, it's kind of 2 years, but it is not certainly 2 years.
No, because the patients who if you look at the patients who had a response on rituximab, then the median duration the patients used rituximab was almost 4 years. And the funny thing is, I remember when we were dealing with Roche at the start, we discussed, shall we go on until progression or just for 2 years, those fixed 2 years. And then I said, don't worry, the median duration of remission in the past is about 6 months. So we would be very happy if we would at least prolong for 1 year or 1.5. And now we have the problem that we have patients more than 5-6 years on rituximab. And what are we going to do? Are we going endless on with rituximab, or should we stop sometime? That's a kind of luxury problem, of course. Yeah.
And there was,
But you have to realize, people say it is expensive, but any salvage regimen is much more expensive than one dose of rituximab every 2 months.
And I think we should still keep in mind that if mantle-cell lymphoma is relapsing,
It's a problem. It's a serious problem.
problem. So I think any kind of remission is worth to be.
Agree. Yeah.
And do you see any toxicity which we have not seen so far with this very long?
Not yet.
Okay.
Not yet. Not more infections, whatever. Yeah.
Okay.
Unexpected infections. Yeah.
Okay.
Yeah.
And now, I think that study is done R-CHOP with our maintenance. Now, there is this still study group where they use bendamustine.
Yeah.
Any comment on that?
Now, we considered for the new study either a combination with bendamustine or a combination with RSC. And there are many studies now going on with bendamustine, so we decided not to duplicate on that.
Okay.
So we decided to have that R-CHOP, R-DHAT, the scheme. And for the maintenance part, because even on rituximab people are still relapsing, we decided to add lenalidomide. So we will have a second randomization in the new study where we will randomize between rituximab as the kind of standard versus rituximab plus lenalidomide.
Okay.
And then hope that at least, well, we probably can improve upon the rituximab data then.
And are you now in the EU consortium splitting in the elderly between the elderly fit ones for the modified DHAP and the elderly unfit? Any new drugs you would like to incorporate in addition?
Yeah, but most people feel that if an elderly patient is able to tolerate 8 R-CHOP cycles, such a patient should also tolerate the adapted cytarabine combination. And any other patient who is not suitable for let's say, is more frail, then we need to adapt.
Okay.
So there are studies going on with, let's say, other schemes, with ibrutinib and so on.
Okay, so BTK inhibitors are now being studied.
Yeah, might be,
as well.
But not yet in the consortium.
Okay.
Yeah.
So if you start with R-CHOP, you said that RFC could be an option for the relapse. Probably then, according to the data, bendamustine, any purinucleotide, these are the kind of drugs. And then probably third line, what we still have are mTOR inhibitors, or certainly any new drugs if there are studies available with the PI3 kinase or BTK inhibitors. Okay, good. So I think what we can summarize, and I think you mentioned it already briefly, is we have to keep in mind that study was with 8 cycles of R-CHOP 21. So if we follow your regimen, we should probably stick to 8 cycles R-CHOP 21. And rituximab was given until progression. So that is something we have to keep in mind. And what we have to keep in mind in Switzerland is that our maintenance has not been approved for the use in mantle-cell lymphoma, but the daily practice is actually encouraging. So when you have a patient and you consider our maintenance, there's a good reason to take your publication, send it to the health insurance, and so far the feedback we have is that most insurers will accept according to that publication.
The results are so impressive, and such a large study. That's
good. So, thank you very much.
Okay, thank you.
It was a pleasure to have you here, and look forward to your presentation. Thank you.